Hi everyone, my name is Anish Kumar and today we are going to talk about pancreatitis. Pancreatitis is a condition characterized by inflammation of the pancreas. The pancreas is a large organ behind the stomach that produces digestive enzymes and a number of hormones. There are two types of pancreatitis. One is acute pancreatitis and second one is chronic pancreatitis. Signs and symptoms of pancreatitis include pain in the upper abdomen. This pain is very intense pain. You can, uh, you know, cannot assume that how this pain could be. I remember one lady said to me that this pain was more than the pain uh, during the childbirth when she delivered her baby. She told that that pain was less than this pancreatitis pain. So you can assume that how intense this pain could be. Apart from this, nausea and vomiting also include. The pain is often goes into the back and usually severe. In acute pancreatitis, a fever may occur and symptoms typically resolve in few days. In chronic pancreatitis, weight loss, fatty stool, and diarrhea may occur. Complications may include infection, bleeding, diabetes, or problems with the organs. The two most common causes of acute pancreatitis are gallstone, blocking the common bile duct after the pancreatic duct has joined, and heavy alcohol use. But apart from these two main causes, pancreatitis may also occur due to any trauma, injury, or any infection could also cause pancreatitis. And certain medication may also cause pancreatitis. And I told you like infections, so infections such as mumps and tumors or also may cause pancreatitis. Chronic pancreatitis may develop as a result of acute pancreatitis. It is most commonly due to many years of heavy alcohol use. Other causes include high levels of blood fats, high blood calcium, some medications, and certain genetic disorders such as cystic fibrosis, among others. Smoking increases the risk of both acute and chronic pancreatitis. Diagnosis: acute pancreatitis is based on a threefold increase in the blood of either amylase or lipase. So these are two enzymes which indicates the situation intensity, right? So in chronic pancreatitis these tests may be normal. Medical imaging such as ultrasound and CT scan may also be useful. Acute pancreatitis is usually treated with intravenous fluids, pain medication, and sometimes antibiotics. One thing I would like to add that the pain medications are seems to be ineffective during uh, the acute pancreatitis. Uh, when pain is in full intensity is there, so medications generally do not work. If work, the duration of relief would be very less. So this is very critical situation, right? And sometimes antibiotics are also used to treat the pancreatitis. Typically eating and drinking are disallowed. In most of the cases when the treatment is given, usually fasting, uh, when the acute pancreatitis or chronic pancreatitis attack is there. So starting few days, complete fasting is recommended and is part of treatment. So we do not allow patient to take orally anything. Typically, eating and drinking are disallowed, and a nasogastric tube is placed in the stomach. A procedure known as an endoscopic retrograde cholangiopancreatography (ERCP) may be done to examine the distal common bile duct and remove a gallstone if present. In those with gallstone, the gallbladder is often also removed. In chronic pancreatitis, in addition to the above, temporary feeding through a nasogastric tube may be used to provide adequate nutrition. Long term dietary changes and pancreatic enzyme replacement may be required. And occasionally, surgery is done to remove parts of the pancreas. Globally, in 2015, about 8.9 million cases of pancreatitis occurred. This resulted in in you know 1,32,700 deaths, up from 83,000 deaths in 1990. Acute pancreatitis occurs in about 30 per sorry about 30 per lakh. Means if there are 1 lakh people, only 30 will get this pancreatitis per year, right? New cases of chronic pancreatitis develop in about 8 per 10,000 people in a year and currently affect about 50 per lakh people in United States. It is more common in men than women. Often, chronic pancreatitis starts between the ages of 30 and 40, while it is rare in children. Acute pancreatitis was first described on autopsy 1882, while chronic pancreatitis was first described in 1946. Let's talk about the signs and symptoms. The most common symptoms of pancreatitis are severe upper abdominal or left upper quadrant, burning pain radiating to the back, nausea and vomiting that is worse with eating. The physical examination will vary depending on the severity and presence of the internal bleeding. Blood pressure may be elevated by the pain or decreased by the dehydration or bleeding. Heart and respiratory rates are often elevated. The abdomen is usually tender, but to a lesser degree than the pain itself. As is common in abdominal disease, bowel sounds may be reduced from reflux, bowel paralysis, fever, or jaundice may be present. Chronic pancreatitis can lead to diabetes or pancreatic cancer. Unexplained weight loss may occur from the lack of pancreatic enzyme. Hindering digestion is also included. Let's talk about some complications that may occur. Early complications include shock, infection, Systemic inflammatory response syndrome, low blood calcium, high blood glucose, and dehydration. Blood loss, dehydration, and fluid leaking into the abdominal cavity, ascites, can lead to kidney failure. Respiratory complications are often severe. Pleural effusion is usually present. Shallow breathing from pain can lead to lung collapse. Pancreatic enzyme may attack the lung, causing inflammation. Severe inflammation can lead to intra-abdominal hypertension and abdominal compartment syndrome. An abdominal compartment syndrome occurs when the abdomen becomes subject to increased pressure, reaching past the point of intra-abdominal hypertension, further impairing renal and respiratory functions, potentially requiring the management with an open abdomen to relieve the pressure. Late complications include recurrent pancreatitis and the development of pancreatic pseudocytes. Pancreatic pseudocytes is a circumscribed collection of fluid rich in the pancreatic enzyme, blood, and non necrotic tissue typically located in the lesser sac of the abdomen. Pancreatic pseudocytes are usually complications of pancreatitis, although in children they frequently occur following abdominal trauma. Collections of pancreatic secretion that have been walled off by scar tissue. These may cause pain, become infected, rupture and bleed, block the bile duct and cause jaundice, or migrate around the abdomen. Acute necrotizing pancreatitis can lead to pancreatic abscess, a collection of pus caused by necrosis, liquefaction, and infection. This happens in approximately 3% of cases, or almost 60% of cases involving more than two pseudocytes and gas in the pancreas. Now let's talk about causes in detail. 80% of cases pancreatitis are caused by the alcohol or gallstones. Gallstones are single most common cause of acute pancreatitis. Alcohol is the single most common cause of chronic pancreatitis. So we remember that the gallstone causes pancreatitis, alcohol causes chronic pancreatitis. But there are many cases which are exceptions, or you can say the other causes are also involved. Triglyceride levels greater than 1000 milligram per deciliter is another cause. So we have to also keep a record of the levels of triglycerides. Medication. Let's talk about the treatment and medication used. There are 7 classes of medication associated with acute pancreatitis: statins, ACE inhibitor, oral contraceptives, hormone replacement therapy, diuretics, antiretroviral therapy, valproic acid, and oral hypoglycemic agents. So these are some drugs. So let's talk about the mechanism of these drugs causing pancreatitis are not known exactly, but it is possible that statins have a direct toxic effect on the pancreas, or through long-term accumulation of toxic metabolism. Meanwhile, ACE inhibitors causes angioedema of the pancreas through the accumulation of bradykinin, birth control pills, and HRT, that is hormone replacement therapy, causes atrial thrombosis of the pancreas through the accumulation of fat, hypertriglyceridemia. Diuretics such as furosemide have a direct toxic effect on the pancreas. Meanwhile, thiazide diuretics causes the hypertriglyceridemia and hypercalcemia, where the latter is the risk factor for pancreatic stones. HIV infections itself can cause a person to be more likely to get pancreatitis. Meanwhile, antiretroviral drugs may cause metabolic disturbances such as hyperglycemia and hypercholesterolemia, which predisposes to pancreatitis. Valproic acid may have direct toxic effect on the pancreas. There are various oral hypoglycemic agents that contribute to pancreatitis, including metformin, but glucagon like peptide 1 is more strongly associated with pancreatitis by promoting inflammation. Atypical antipsychotics such as clozapine, risperidone, and olanzapine can also cause pancreatitis. Infections, a number of infections or infectious agents have been recognized as a cause of pancreatitis, including viruses, Coxsackie virus, cytomegalovirus, hepatitis B virus, herpes simplex virus, mumps, varicella zoster virus, bacteria such as Legionella, Legionella, Leptospira, Mycoplasma, Salmonella, fungi such as Aspergillus, parasites such as Ascaris, Cryptosporidium, and Toxoplasma. Other common diseases include trauma, autoimmune disease, high blood calcium, hypothermia, and endoscopic retrograde cholangioscopy. Pancreatitis is common congenital formation of pancreas that may last some rare case. Diabetes type is associated with a 2.8-fold higher risk. Less common causes include pancreatic cancer, pancreatic duct stones, vasculitis, inflammation of the small blood vessels in the pancreas, and porphyria, particularly acute intermittent porphyria and erythropoietic protoporphyria. There is an inherited form that results in the activation of tryptogen with the pancreas leading to autophagy in one genes include cinnamon, which code for tryptogen, SPIC1, which code for trypsin inhibitor, or cystic fibrosis, transmembrane conductance regulator. Clinic get match is often used to remember the common causes of pancreatitis. G for also ethanol, T for steroids, M for mumps, A for autoimmune pancreatitis, S for scorpion sting, H for hyperlipidemia, and H for hypothermia, H for hypersympathetic, for endoscopic retrograde cholangioscopy, D for drugs, commonly azathioprine, valproic acid, liraglutide. Now let's talk about diagnosis, how we can diagnose it. Differential diagnosis for pancreatitis include, but is not limited to, pancreatitis, cholelithiasis, perforated peptic ulcer, bowel infection, small bowel obstruction, hepatitis, and mesenteric ischemia. Diagnosis requires two of the three criteria: characteristic acute onset of abscess or abdominal pain that may lead to bags, so see the serum amylase or lipase levels more than 3 times the upper limit of normal. An imaging study with characteristics is CT, abdominal ultrasound, or endoscope ultrasound can be used for diagnosis. Amylase lipids are too and produced by the pancreas. Elevations in lipase are generally considered a better indicator for pancreatitis as it has greater specificity and has a longer half-life. However, both enzymes can be elevated in other disease states. In chronic pancreatitis, the fecal pancreatic state 1 FPE1 test is a marker for exocrine pancreatic function. Additional tests that may be useful in evaluating the chronic pancreatitis includes hemoglobin 1AC or A1C, hemoglobin A1C, immunoglobulin G4, rheumatic factor, and anti-nuclear antibody. For imaging, abdominal ultrasound is convenient, simple, non-invasive, and inexpensive. It is more sensitive and specific for pancreatitis from gallstones than other imaging modalities. However, in 25 to 35% of pancreatitis patients, the view of pancreas can be obstructed by the bowel gas, making it difficult to evaluate. A contrast enhanced CT scan is usually performed more than 48 hours after the onset of pain to evaluate the pancreatic necrosis and extra pancreatic fluid as well as predict the severity of the disease. CT scanning earlier can be falsely reassuring. ERCP or an endoscopic ultrasound can also be used if a biliary cause for the pancreatitis is suspected. Now let's talk about the treatment, the main part and the important part. The treatment of the pancreatitis is supportive and depends on severity. Although it is extremely severe, so morphine is generally is suitable for pain control. There are no clinical studies to suggest that morphine can aggravate or cause pancreatitis or cholecystitis. The treatment for acute pancreatitis will depend on whether the diagnosis is for the mild form of condition which causes no complications or the severe form which can cause the serious complications. Mild acute pancreatitis. The treatment of mild acute pancreatitis is successfully carried out by admission to a general hospital ward. Traditionally, people were not allowed to eat until the inflammation resolved, but more recent evidence suggests that early feeding is safe and improves outcomes and may result in an ability to leave the hospital sooner. Due to inflammation occurring in the pancreatitis, pro-inflammatory cytokines secreted into
The bloodstream can cause inflammation throughout the body, includes the lungs, and can manifest as ARDS, because ARDS is acute respiratory distress syndrome. Because pancreatitis can cause lung injury and affects normal lung function. Supplemental oxygen is occasionally delivered through breathing tubes that are connected via the nose. Example, nasal cannulae or via mask. The tubes can then be removed after a few days once it is clear that the condition is improving. Dehydration may result during an episode of acute pancreatitis, so fluids will be provided intravenously. Opioids may be used for the pain when the pancreatitis is due to gallstone. Early gallbladder removal also appears to improve outcomes. Severe acute pancreatitis. Severe pancreatitis can cause organ failure, necrosis, infected necrosis, pseudocysts, and abscess. If diagnosed with severe acute pancreatitis, people will need to be admitted to a high dependency until the intensive care unit. It is likely that the levels of fluid inside the body will have dropped significantly as it diverts bodily fluid and nutrients in an attempt to repair the pancreas. The drop in the fluid levels can lead to reduction in the volumes of blood within the body, which is known as hypovolemic shock. Hypovolemic shock can be life threatening as it can very quickly starve the body of the oxygen rich blood that is that it needs to survive. To avoid going into hypovolemic shock, fluids will be administered intravenously. Oxygen will be supplied through the tubes attached to the nose and ventilation. Equipment may be used to assist with breathing. Feeding tubes may be used to provide nutrients. Combined with appropriate analgesia. As with mild acute pancreatitis, it will be necessary to treat the underlying cause, gallstone, discontinuing medicine, cessation of alcohol, etc. If the cause is gallstone, it is likely that the ERCP procedure or removal of the gallbladder will be recommended. The gallbladder should be removed during the same hospital admission or within 2 weeks of pancreatitis onset so as to limit the risk of recurrent pancreatitis. If the cause of pancreatitis is alcohol, cessation of alcohol consumption and treatment for alcohol dependency may improve pancreatitis. Even if the underlying cause is not related to alcohol consumption, doctors recommend avoiding it for at least 6 months as this can cause further damage to pancreas during the recovery process. Oral intake, especially fat, is generally restricted initially, but early early eternal feeding within 48 hours has been shown to improve clinical outcomes. Fluids and electrolytes are replaced intravenously. Nutritional support is initiated via tube feeding to sur- surpass the portion of the digestive tract most affected by secreted pancreatic enzyme if there is no improvement in the first 72 to 96 hours of the treatment. Prognosis. Severe acute pancreatitis has mortality rate around 2 to 9% higher where necrosis of the pancreas has occurred. Severe scoring systems are used to predict the severity of an attack of pancreatitis. They each combine demographic and laboratory data to estimate the severity or probability of death. Examples include Apache 2nd, Ranson, Bishop, and Glasgow. The modified Glasgow criteria suggests that a case be considered severe if at least three of the following are true. Age is above 55 years, blood level oxygen level less than 60 millimeter of mercury or 7.9 kPa. White blood cells are more than 15,000 microliters. Calcium levels are less than 2 millimole per liter. Blood urea nitrogen is higher than 16 millimole per liter. Lactate dehydrogenase more than 600 international per liter. Aspartate transferase is more than 200 international unit per liter. Albumin is less than 32 gram per liter. Glucose is more than 10 millimole per liter. This can be reimbursed using the unique pancreas. Pancreas PO2 oxygen is less than 60 millimeter of mercury or 7.9 kPa. Age is more than 55. Neutrophilia, white blood cells more than 15,000 microliter. Calcium less than 2 millimole per liter. Renal function BUN more than 16 millimeter per millimole per liter. Enzyme lactate dehydrogenase LDH is more than 600 international unit per liter. Aspartate transaminase is more than 200 international unit per liter. Albumin is less than 32 gram per liter, and sugar or glucose is more than 10 millimole per liter. The BISAP score blood urea nitrogen level is more than 25 milligram per deciliter or 8.9 millimole per liter. Impaired mental status, systemic inflammatory response syndrome, age over 60 years, pleural effusion has been validated as similar to other prognostic scoring system. Epidemiology. Globally, the incidence of acute pancreatitis is 5 to 35 cases per 1 lakh people. The incidence of chronic pancreatitis is 4 to 8 per lakh with prevalence of 26 to 42 cases per lakh. In 2013, pancreatitis resulted in 1,23,000 deaths up from 83,000 deaths in 1990. Cost in adults in the United Kingdom, the estimated average total direct and indirect cost of chronic pancreatitis is roughly £79,000 per person on an annual basis. Acute recurrent pancreatitis and chronic pancreatitis occur infrequently in children but are associated with high healthcare costs due to the substantial disease burden. Globally, the estimated average total cost of the treatment for children with these conditions is approximately $40,500 per person per year. Other foods or animal foods or in animals, fatty foods may cause in canine pancreatitis in dogs. So this was all about pancreatitis. Hope you would have learned something from this session. So thank you so much. Have a great day and keep learning.